So Gopal, all yours.
Okay. I thank Rahul, my friend Harpreet, and Dr. Sarkar for initiating this discussion on various techniques of dealing with the prostate. Now, taking on from Dr. Sarkar's words that laser usage has been slow, I thought that 10 minutes is too short for discussing the technique of a rather unfamiliar surgery like HOLEP. So rather we discuss about the philosophy or the passion of people who are continuing to do HOLEP for the last 2 decades, and why it has stood the test of time in spite of us having TURP, which is essentially the mother of all endoscopic surgeries, and its sibling, the bipolar surgery. So while we are discussing the philosophy of why you should do HOLEP, in the words of Dr. Harry Herr, the prostate has been attempted to be dealt with by various ways: scarified, charred, burnt, ablated, etc., etc., etc. And the main reason why so many techniques have evolved is that surgeons from time immemorial have been afraid or worried about the bleeding from the prostate, because bleeding not only increases the immediate morbidity and the complications, which may even be death in the past, but more important than that, bleeding actually reduces the visibility during surgery and leads to incomplete removal, residual adenoma, regrowth of the prostate, dysuria, recurrence, obstruction, infection, etc., etc. So when we compare it, a resection with an enucleative surgery of an organ, there are some natural advantages. Enucleation means that you are going to remove it in the least vascular plane of the capsule of that gland. And the second thing is that since you're going through the plane of the capsule, you're shelling it out intact without leaving any remnants. The natural fallout of these two advantages is that the enucleation method will always be the same, whatever be the size of that particular organ. And the second thing is, since you're going in a avascular plane, there will be minimal vascular surprises, which will naturally lead to an easier learning process of that particular surgery. Now, when we talk about TUR, these words are rather important. The experience of a resectionist depends more on his hemostatic capabilities than on his resective ability. And we all remember in the past, when we have had problem with bleeding, we have always called a senior surgeon who is more experienced with dealing with, with the bleeders and the hemostasis. And once he is able to do the good hemostasis, he goes on to resect the rest of the incomplete removed gland. So this is the difference between a resection and an enucleation. Now, HOLEP leads us to basically an amalgamation of the best of lots of procedures. TURP, it's an endoscopic procedure as for TURP. HOLEP achieves complete enucleation in an avascular plane, and more important, it can deal with any size of the prostate. And the other common factor with a bipolar TUR is that since it's done under saline, there is really no TUR syndrome. So the HOLEP is basically achieving the best of everything that you can have. Plus, lots of pluses. It is safe with antiplatelets, similar to green light. It is affordable, unlike a green light laser, and there is really no scar formation, unlike the NDAC laser, the green light, and some of the low-powered thulium lasers. So it has a lot of advantages. Now, of course, there are a lot of criticisms about HOLEP, and that is why the laser usage has been slow, and mainly because we say that the learning curve is rather long, it's a time-taking operation, and of course, it has been labeled with the curse of stress incontinence, which it's unable to get rid of, even after 20 years. Now, what are the criticisms? Why is the long learning curve? Well, actually, if you see laparoscopy, as the curve is much, much longer, but we have to learn it out of compulsion because there is really no other alternative. The only alternative is open surgery, which we do not want to do. So we all are forced to learn laparoscopy. The second thing is impatience. We often, in the midst of the HOLEP procedure, we convert to a familiar surgery, that is TURP, and thereby we do not acquire or we de-skill our HOLEP learning. The third mistake that we do, that we reserve HOLEP only for larger prostates while doing TURP on the smaller prostates. And this is not the way to begin. And the fourth problem is that we do not allot adequate time for learning this procedure. We are often in a rush keeping it in the midst of a busy list, and therefore you don't have time. And this leads to the anesthetist unhappy because you're having a long operative time, increased cost, and of course, the label of incontinence, whereas actually the risk of incontinence following a robotic radical prostatectomy is much higher, but we have all accepted it. Why? Why do we not accept uh, the actual lack of incontinence or the same risk of incontinence between HOLEP and a TURP, whereas robotic prostatectomy, which is the best form of prostatectomy, actually has a higher risk of incontinence? Now, what are the solutions? You must give adequate time to learn this procedure. In the words of Dr. Pankaj Maheshwari, which I quite agree, give at least 1.5 hours OT time. Space your other OTs. Do not be in a rush. Do not keep many cases so that you are learning it in a relaxed way. And how do you reduce your learning curve? Start with smaller prostates initially, and once you are successful, then when you take on a larger prostate, you do, if necessary, one lobe at a time. You may do only the middle lobe or one lobe and middle and the lateral lobe, and then do the TURP of the other lobe so that you do not take a long time. And this is the way you gradually increase your speed and your confidence. And if you find that you've taken a long time, you can always do the morcellation after 48 hours. In fact, the morcellation is a lot easier after 2 days, as we all know. The third thing is regarding the increased cost of surgery. You must buffer the cost. Well, reduce your operative fees, keep a smaller cost, take this as your learning cost, as if you are attending a workshop. This is your self workshop. So this is how you buffer the cost of surgery, and in turn, you are actually learning. And lastly, learn the operation properly for zero incontinence. Now, this is my HOLEP learning curve. As you can see, I took almost 60 to 70 cases to actually learn the procedure well, whereas because I did not have a continuous mentor, I went for training intermittently, whereas my own registrar, who was being continuously mentored by me, was able to achieve reasonable scales of doing a moderate sized prostate within just about 30 or 40 cases. So this is the importance of mentorship. Now, what does mentorship teach you? Mentorship teaches you the surgical landmarks and how to look for it. There are certain safe anatomical landmarks like the veru, bladder neck, the ureteric orifices, and there are some danger areas where you need to avoid capsular perforation, you need to preserve the trigone. All these will go a long way in actually preserving continence. Now, what is mentorship? Basically, if you see, the HOLEP is a copybook surgery. You have certain identical steps. There are no vascular surprises, unlike a TURP where you are going through the gland and you often are encounter severe bleeding. There are standard 2 or 3 commissurotomies depending upon the type of HOLEP that you want to do. As a beginner, I would suggest you always do a 3-lobe HOLEP. The second thing is the enucleation plane will always be the same. And once you achieve the plane of the capsule, you go in the same plane, you do not encounter any major bleeders, and you have an optimal joule and a frequency combination for coagulation, ablation, and for various special areas of the prostate, like near the veru or near the sphincter and other areas. And lastly is to exit with a safe morcellation. So the way to learn HOLEP is actually not very long. There are only certain standard steps, and it doesn't take very long to learn them. Now, coming to the fact that we have all decided that enucleation is certainly a better technique, as Dr. Sarkar said in his last words before he closed, enucleation is enucleation is enucleation. Now, we have 2 different types of enucleative lasers, the holmium versus the thulium. For the holmium, you can have a 60 to 100 watt laser. We are not talking about the 120 watt. And the thulium should essentially be a high-powered laser of at least 110 to 150 or 200 watt. Now, one is a pulsed wave and the other is a continuous wave. Now, why do we insist on a high-powered thulium? The reason is we have used low-powered 70-watt thulium in the past, and we have encountered a lot of charring. So therefore, it is important to have a high-powered laser. If you see, the cost between the 2 machines is more or less the same, combined with the cost of a morcellator, it almost comes to 80 lakhs to a crore of rupees. So there is not really much cost difference between the two. Now, what is the other difference? The thulium, being a continuous laser, is actually a faster knife. It's like it's like a knife going through butter. And that's why it appears to be technically easier, because you can actually change the shape or change the plane of resection or enucleation that you want. Whereas the holmium has a bubble effect. And therefore, this will separate the adenoma from the capsule. And this is therefore a precision cut. Now, that is why HOLEP, there is no variation in HOLEP. It is only one surgery. Whereas you have various different types of thulium prostatectomy. You have the ablation for a small prostate. You have the resection for a moderate sized prostate, similar to doing a TUR. And ultimately, you have the vapoenucleation or the enucleation for the bigger prostates. This picture shows very nicely that when you do a thulium enucleation, you can go through any plane. So you risk leaving behind some amount of tissue near the capsule, which you can never do in a HOLEP. You can do a bad thulium prostatectomy, but you can never do a bad HOLEP. That is the key word. And therefore, you find that the PSA drop after HOLEP is much more than a thulium. Now, is the learning curve less for thulmium rather as compared to holmium? Actually not. If you decide to perform enucleation, the learning curve will exactly be the same. And why do we insist on enucleation? Enucleation is the key to remove a large prostate, which is the ultimate target. And enucleation is the key to remove a gland in an avascular way. And only enucleation will prevent the complications of laser, that is charring, scarring, dysuria, and other things. So with these things, I will end with these last words, which I picked up from a can of Heineken beer, is that everyone is legendary at something. Do whatever you do it well and excel at it. Cheers to everyone.
You have ended with a fantastic saying that do whatever you do is the best in your hands.